Good morning, my name is Dr. Jameel. I'm a clinical research fellow at Imperial College London, working with Professor Gedrich's team on movement disorders. Our talk is entitled Targeting the Zonar Inserter, also known as the ZI, in addition to the ventral intermediate nucleus of the thalamus, which is the VIM, with MR-guided focused ultrasound to treat medically refractory essential tremor, and I'll be presenting our outcomes at 2 years. MR-guided focused ultrasound has been proven to be a safe and effective treatment in essential tremor by several trials of unilateral VIM ablation. However, deep brain stimulation studies previously have demonstrated other tremor-specific nuclei, including the zonar inserter. The zonar inserter is not yet established as a treatment site in MR-guided focused ultrasound. At Imperial, we do target the ventral intermediate nucleus of the thalamus, and then, after careful assessment for residual tremor and any adverse effects, we proceed to a second target, the zonar inserter. We performed a unilateral VIM and ZI ablation study with our first patient treated in July 2016, and we treated 13 patients in total, and here are their demographics. We had the same inclusion and exclusion criteria as ET00 which many of you are familiar with. We use the ACPC line to target the anterior VIM and then tailor treatments to patient's response, before moving to the ZI target, which is approximately 3 mm inferior and 0.5 mm posterior. And again, we tailor treatments to patient's response. We use several outcome measures at Imperial, including Bain and Finley spirals, which are then scored by 3 blinded movement disorder neurologists, the clinical rating scale for tremor, the quality of life in essential tremor, and regular assessment for adverse effects. Of note, one patient was recruited to the bilateral study at 12 months, and thus is excluded from our 24-month dataset presented here. We found that there was an improvement across all our outcome measures. Our mean spiral score improved by 49.5% intraoperatively. The clinical rating scale for tremor from baseline to 24 months improved by 55.1%. And from that, the CRST, the treated Arm Tremor Score, improved to 72.9%. The quality of life in essential tremor from baseline to 24 months improved 37.6%. Here is an example of one of our patient's spirals immediately pre-procedure, and then after VIM ablation, and then after ZI ablation. And you can see there's serial progression across the spirals. We found across all 13 patients that the mean spiral score improved by 27.9% after VIM ablation, and after ZI ablation there was an additional 24.6% improvement in their spiral scores. And here is the spirals across the 13 patients. Overall, there was a 49.5% improvement intraoperatively. Here is the mean CRST score, and after MR-guided focused ultrasound, there was an improvement from baseline to 24 months. This was 55.1%. Here is the treated arm score derived from the CRST. Again, after the treatment, you can see there is improvement, and from baseline to 24 months, 72.9% improvement. And even though we did a unilateral procedure, we found that there was the 72.9% improvement in the treated arm, but also a 30.7% improvement in the untreated arm. And this we attribute to the ZI, which is known to have a bilateral function in primates, and this is further evidence in humans that there is a bilateral function. Across the study period, we had no serious life-threatening adverse effects, and the majority of our adverse effects resolved by 6 months. However, at 24 months, we did have 2 patients with persistent adverse effects. And here are the adverse effects across the study period. You can see the majority of adverse effects occurred on treatment day, including 2 patients with paresthesia, but this resolved by day 1 and is most likely secondary to edema. We attribute our low rates of paresthesia to an anterior approach to the VIM. The vast majority of adverse effects had resolved by 6 months, and at 24 months we had 1 patient with chorea and 1 patient with unsteadiness. Ataxia or unsteadiness has been reported in relation to VIM ablation, but Career has not. However, we know that subthalamic nucleus or STN targeting in DBS is associated with Career. On further analysis and discussion with the applications and physics specialists, we came to understand the increased risk of focal spot elongation in the cranial caudal direction with deeper sonications such as the ZI, which increases the risk of encroachment onto adjacent deeper structures such as the STN. So future FUS treatments, and certainly all the treatments we've done since this study, have taken into account this spot elongation, and we have not had any further incidences of Career. We have demonstrated the utility of targeting the anterior VIM and ZI with stable tremor suppression over 24 months and no paresthesia beyond treatment day. There is also a bilateral improvement in the tremor, most likely secondary to ZI ablation. However, there is an increased risk of Career with ablations of deeper structures, including the ZI, and therefore we need to be careful of deeper sonications, and further studies are needed to compare VIM alone and VIM plus ZI. Thank you.